Reconstruction is a process. It's a process that involves multiple surgeries. Now, as much as we all want to just try to get the reconstructive process and breast cancer treatment in general over with as quickly as possible, the most important thing to remember is that the process has to be safe. So your safety is the most important thing that overrides everything else. The second most important thing is getting a great outcome, a beautiful aesthetic result, restoring the breast or both breasts to its to a normal shape, to a normal contour, and to have beautiful symmetry. That's the second most important goal, but the most important thing is your safety. So I'm going to talk about the use of a tissue expander in the context of safety. Because the very first step that I always talk with patients about who are undergoing mastectomy is to place a tissue expander into the breast pocket at the time of the mastectomy. Now, a tissue expander is just a water-filled temporary implant. In other words, it's designed to be removed from the breast at the time that the definitive reconstruction is performed. Why do we even need to do that first step? Why can't we just do the definitive reconstruction right at the time of the mastectomy? Well, the reason we need to put a temporary implant in place is for two reasons, again, related to safety. First of all, the goal of a mastectomy is to remove all the tissue and, of course, remove the cancer. That's the most important part of the mastectomy. What if there's a positive margin? What if there's some cancer that has been inadvertently left behind during the course of the mastectomy? Well, then the breast surgeon has to go back and remove that extra tissue that had the positive margin. In other words, try to find where that residual breast cancer was left behind and remove that tissue. That involves a second surgery. So you wouldn't want to do a whole complete reconstruction only to have to go back and undo it, so to speak. So there's an important consideration of the possibility of a positive margin. Now, if the breast cancer is very small and it's contained within the breast tissue and far away from the breast skin, then there's less chance of having a positive margin. So that's not so important. So the bottom line is that it really depends on each individual patient's unique situation. How big is the breast cancer? Where it's located? Is it close to the nipple? Is it close to the breast skin? Is it fairly large such that we're concerned about a possible positive margin? So there's that safety concern of making sure that breast cancer is completely removed. Most important thing. And this is where a tissue expander comes into play. A tissue expander is, again, a temporary implant that's designed to be removed very easily, and it holds the breast pocket, it holds the shape of the breast so that the patient can finish her breast cancer treatments completely, and then we can move to the definitive reconstruction. That's why it's important to have that first step. The second safety reason to place a tissue expander is because it is think of it as an inflatable balloon. When the balloon is completely deflated, it's like a pancake. It doesn't have really any shape. It doesn't have any weight to it. It's easily placed in the breast pocket. Now, why is that related to safety? Why is that so important? Well, it's because if you think about it, after or during a mastectomy, when the breast surgeon removes all that breast tissue, he or she is also removing much of the blood flow to the overlying breast skin. And we leave the breast skin intact because that's what's going to give the shape and the appearance of a normal breast after reconstruction. But at the time of the mastectomy, the breast skin is very delicate. The blood flow to the breast skin has been reduced severely by virtue of removing the breast tissue from the breast skin. And so if there's not enough blood flow to the breast skin, then the breast skin will die. That's a process called necrosis or tissue death. It's something that is not necessarily harmful to one's health, but if left untreated, it can be a safety problem. So we want to avoid tissue death or necrosis as much as we possibly can. Now, circling back to why a tissue expander helps us to avoid that risk. If you think about it, a tissue expander completely deflated has no weight to it. So when I place a tissue expander into the breast pocket after mastectomy, there's no pressure that's being placed on the breast skin. So because there's no pressure on the breast skin, then that breast skin can lay very gently and delicately, and it can recover its blood flow. It takes about 2 weeks for the breast skin to recover its normal blood flow and to be healthy again, for that breast skin to have a nice, healthy blood flow. It takes about 2 weeks. So on the flip side, if I were to place a fully filled large implant into the breast pocket, then that puts a lot of pressure on that delicate breast skin and potentially reduces the blood flow of the breast skin even further, thereby putting the breast skin at risk for necrosis. So it's very important to minimize the pressure and the weight of any implant or anything really on that delicate breast skin. That's why I'm very careful to advise my patients that I don't want any pressure, external pressure on the delicate breast skin after mastectomy. I want them to be very gentle with their activities so that we can bide our time over 2 weeks and let the delicate breast skin recover fully and to get a healthy blood flow back. It just takes time. It's not something that we can rush. It's just the body's way of healing itself. So we have to respect the body's way of healing itself, and the key is to use a tissue expander. So let me show you what a tissue expander looks like and how I approach using a tissue expander. This is a tissue expander, and it is a saline-filled implant. So think of it as a water balloon, where you can add water to it, you can remove water from it, and the point again is to minimize the amount of pressure or weight that the implant has on a very delicate breast skin right at the time of the mastectomy. So just to give you a sense of how this works, looking directly at the tissue expander, it's a three-dimensional structure, and again, think of it as a water balloon. You can see some of the saline or the water on the inside. I've put a couple hundred cc's of saline into this particular one. And what you notice is that it's pretty flexible. I mean, I can sort of squish it around, and the reason for it being so flexible is so that it can expand, hence the name tissue expander. This shell is made of silicone and it can stretch out. So in fact, I could keep putting saline or water into this expander and stretch the shell, and as a consequence, it stretches the breast skin, thereby creating the breast shape. If you look at it from the side, it has a little bit of a breast shape. It's flatter up top, and then as you go down, it has more of a curvature and a fullness at the bottom of the tissue expander, just like a real breast implant would. And then flipping it to the back, there's a little window here, which it doesn't have any particular function. But through the window, you can actually see this kind of metal device there. The metal device, flipping it around to the front, this is the front of it. The metal device is the port. It's just called a port into which I can place a needle and I can instill the saline. So here's an example of that. This is just a syringe of saline, which is just salt water, and here's a needle at the end. So all I do, if you can imagine this tissue expander sitting underneath the breast skin, all I do is place the needle into the port, just like this, okay? And then I just simply push the plunger, and then the saline just went completely into the tissue expander. And that's our clever way of being able to fill it without popping the water balloon. So on a normal water balloon, if you put a needle into it, it'll pop. But this is a very clever device, having an integrated port that's protected, and it self-seals so that when I place the needle and then take it out, it's completely sealed up. So the saline stays inside the tissue expander and nothing can get out. Very useful device that way. Now, these tabs, you might be wondering, what are these things sticking out? Well, these tabs, sometimes surgeons will use these tabs to secure, with suture, the tissue expander to the chest muscle so that it doesn't rotate, it doesn't flip around, so that it stays right where it is. I make that decision in the operating room, depending on what the circumstances are. I might decide to do that. If I feel that the tissue expander is nice and secure and in place, then I won't need to do that. So that's an intraoperative decision. Now, I have a little volume in here, and you can see that obviously the tissue expander is not full. It's not being stretched out. So this is about how much volume I would have in the tissue expander when I'm placing it into the breast pocket at the time of the mastectomy. And with this small amount of volume, I want to be sure, again, that there's no extra pressure or extra stretching kind of weight or pressure on the delicate breast skin at the time of the mastectomy. Very, very important because, again, we want to minimize the risk of tissue death or tissue necrosis. And by having just a limited amount of volume in the tissue expander, then when I place it into the breast pocket, then I can be sure that there's no adverse pressure on the breast skin to potentially put it at risk for tissue death. One question that I commonly get is, at the time of the mastectomy, how do I work with the breast surgeon to perform the surgery? And are the surgeries combined? Well, the answer is yes. I work very closely with the breast surgeon so that we can be the most efficient that we possibly can and perform both parts of the surgery as safely and as efficiently as we possibly can. So obviously the breast surgeon's goal is to remove the breast cancer and to perform the mastectomy and get all the breast tissue out. And my goal is to place the tissue expander and finish the surgery. So let's talk about one-sided reconstruction. Patients undergoing a one-sided mastectomy. So in that scenario, the breast surgeon will start with his or her portion of surgery, which is the mastectomy. Once the surgeon has completed that portion and they're ready for me to come in, then I will come into the operating room and I'll start my process. Usually what I will do is prep the breast skin again. So in other words, I use this cleansing solution to make sure that everything is fresh and clean and perfectly sterile. The reason is not because I suspect that the sterility has been compromised, but only because I want to take that extra step to minimize the chance of infection. When I come in and I begin, I will announce to the team exactly what the procedure is that I intend to do, placing a tissue expander on the left or the right side of the breast. That's called a timeout, surgical timeout, to make sure we're all on the same page. And then I'll begin by first making sure that there's no bleeding from the tissues. One thing always in the back of our minds is the possibility of what's called a hematoma, which is a blood collection under the skin. A hematoma can occur in about a few percent of the patients that we treat with this procedure. If a patient had a hematoma, then she would have to be taken back to surgery and we'd have to find the bleeding source. So it's very important to achieve what we call hemostasis. Hemostasis just means making sure there's no bleeding from the tissues and that we can proceed. The first thing that I do is I elevate the chest muscle. Now the chest muscle is called the pectoralis major muscle. It's a push-up muscle or it's a bench press muscle. And the tissue expander is placed underneath the chest muscle. Why do I need to do that? Again, for safety, because it adds an extra healthy layer of tissue between the tissue expander and the breast skin, which is very delicate. Having that buffer of tissue helps to prevent excess pressure on the breast skin in order to reduce the risk of tissue necrosis. So what I first do is I elevate the chest muscle away from the rib cage and I create a pocket underneath the chest muscle. Once I've created a pocket of adequate size, then I make sure again that there's good hemostasis, no excessive bleeding, and then that tissue cover is what's going to cover the top part of the implant. Now, there has to be something that holds the tissue expander from the bottom, because after a mastectomy, there's not really much support for the tissue expander. So gravity is always going to be pulling that tissue expander down. And so what do I use? Well, I use something called acellular dermal matrix. Acellular matrix is basically skin tissue that has been taken from some external source. The external source can be from an animal or it can be from a human. The most common acellular matrix material that is used is it comes from a human source, so a cadaver. So skin has been harvested, it's been processed in a way that removes all the cells from it so that your body can't reject it as a foreign material. And what the acellular matrix does is it provides a sling or a hammock in order to prevent the tissue expander from being pulled out of place by gravity. Without that, then the implant can just kind of slide out of place and the breast doesn't look like a normal breast shape again. So the use of some support device is very important. So we talked about the pectoralis major muscle coming over the top of the expander and then the acellular matrix on the undersurface to hold it in place. That's what creates the support for the tissue expander, and it also helps to create the shape of the breast. And that's really where the art of it is, of this first part of surgery. It's really the art of making sure that the pocket and the shape really can recreate the breast shape that was lost from the mastectomy. And so there's no cookie cutter way to approach that. It's just very individualized, and in the operating room, make sure that that shape is as perfect as it possibly can be. A common question that a patient will have when I talk to her about having a tissue expander is, how often do I need to come back into the office to have a tissue expander fills, and does it hurt? Well, to answer the first question, typically I will start the expansion process once the drains are removed. Sometimes I'll start a little bit earlier, but at about 3 weeks or so after surgery, then I'll start having the patient come into the office for literally a 10-minute, 15-minute visit just to check on everything, make sure she's healing appropriately. There's no evidence of tissue compromise or necrosis. The incision's healing well, and I'll do the first installation of saline into the tissue expander. And the way that I do that is I just place a needle gently right through the breast skin. I can find where that magnetic port, that metal port, is located. I can locate it just by feel and also with a magnetic device to point me in the right direction. I place the needle very carefully through the breast skin into the port, and I can inject or instill some saline. Typically I'll instill between 60 and 100 or 120 cubic centimeters or milliliters of saline at a time. And to answer the second question, it does not hurt. After a mastectomy, the breast skin is numb because all the nerves that gave sensation to the breast skin have been cut as a result of the mastectomy. And that's a fact that every patient who has a mastectomy lives with, and to be honest, it's not something that's particularly bothersome to patients. You just get used to it, used to the numbness and lack of sensation there. And the advantage of doing these tissue expander fills in the office is that we don't need to use any kind of numbing medicine. So it is a comfortable procedure to perform in the office.